Well, thank you very much, Dr. Cohen, and thank you for the people who put this together and do all the organization. Thank you for the people that is here for the lecture, and also the people that is looking this online and maybe in a recording. I changed the title a little bit. Instead of saying basics, I'm putting fundamentals in neuroimaging. And it's because what I'm going to talk is what is related to imaging of the brain and spine, but mainly trying to see different modalities to give you an overview of how we do this. I don't have any disclosures. So the goals are first doing an overview of the different modalities, then talking about the specific benefits and challenges using CT, same thing, benefits and modalities using MRI, and the importance and risk of using contrast material. These are the modalities that we are going to talk today. It's going to be X-rays, ultrasound, CT, and MRI. I want to focus more on CT and MRI, so the lecture is going to take a little more time in those topics, but I'll do a brief description of the other two. Before we start with the different modalities, I want to take your attention to this very useful tool. It's called the American College of Radiology, ACI Appropriateness Criteria. So what is this? This is a tool that is free online that you can go and type it in and give you different scenarios. If you see on the top part, you can see the clinical condition. You can use any condition. In this case, we're talking about head trauma. There are different variants, if it's minor, if it's moderate, etc. And what it does is, after you give the clinical scenario, it will tell you what is the best radiological procedure. It will give you a rating that you can see in the second column, some comments, and then the level of radiation. So the rating is going to be from 1 to 9, being 9 the best that you should do. And for example, if you're doing a head trauma, the most recommended thing will be CT of the head without contrast. That's a rating of 9. We don't have extra comments. And this is the amount of radiation. A second option, for example, will be, let me see if I do this on the screen. Oh yeah, helps in this, works in the screen too. If you have an MRI of the head, there'll be 5. It's not great. There's some comments. Some people agree, some people don't agree. The good thing is it doesn't have radiation. So this is very helpful, especially for clinicians that are not radiologists, but radiologists, we use it all the time too. So the first one we're going to talk about is conventional X-rays. Conventional X-ray has many utilities, but main ones that we use in neuroradiology is want to make sure that the VP shunt is intact. We want to make sure that there's not a radiopaque foreign body. Other things like sutures and fractures have been used in the past, but as I will talk about later, it's better to use a 3D imaging on a CT because it can be very confusing on pediatrics. Second modality, ultrasound. We have next to each other on the left is an ultrasound of the head, and on the right we have a CT of the head with the same patient. So we can see that hyper density within the ventricles. This is blood, and it can be a little better characterized on the CT. But what's the importance of the ultrasounds? Sometimes a CT can give more detail and the MRI can give more detail. Should we do ultrasound? Yes, of course. Ultrasound, first of all, doesn't give you any kind of radiation. And second, it can be done next to the patient. So let's say this patient is in the ICU or is in a critical condition. You cannot take the patient to the CT or the MRI suite. You can just take the ultrasound machine and do the ultrasound on the bedside. If you need to do follow-ups, for example, in our babies in the NICU, you don't need to do the transportation to the CT or the MRI. You can just do follow-ups every so often. You can do it even the same days, a couple of times, and it wouldn't incurring any more radiation or any other problems. So I love ultrasound. So for CT, this is what I'm going to talk a little bit more. The following lecture is actually going to be Dr. Siddiqui talking about brain trauma. So I have some trauma cases over here, but I'm just going to fly through them and give you just pinpoints. Okay, so for CT, why is good? It's really fast, so you don't have much motion artifact, and even if you have it, you can repeat it if it's necessary. It's very accessible because you can see it in almost all hospitals. You only need one acquisition, and then you can do reformats in different planes. For example, this is one acquisition. I put less than half a second, that is actually less than that. And you can get that pre-reconstructions. You can have axial, coronal, sagittal, and then you can do even a bone algorithm, and everything is from the same acquisition. So you don't need to have the patient coming back if you think, oh, maybe I need to do some specific volumetric because I need thinning slices, or I want to do the bone window. We can do all the reconstruction for you if you need it. You just have to ask us. So this is for the head trauma. Let's see. I know why all my video is not working, but it's okay. So I'm going to show some cartoons that I did with actual images from some of our patients to describe a little bit more how the spaces are being occupied. So this is epidural hematoma. You can see this kind of biconcave or lentiform shape collection, hyperdense, that usually because you have an acute hemorrhage. And because usually this is from arterial origin, you're going to have a lot of push. It's going to grow really fast and it's going to push the brain. This is subdural hematoma. Subdural hematoma usually is more like a half a moon shape. Usually they are venous and the growth is a little slower, but don't confuse them as some people say that if it's an epidural, you need to get neurosurgery involved right away. And if it's a subdural, then you can just observe. That's incorrect. You can have a very critical patient with a subdural that can grow pretty fast and can give you a herniation and kill your patients. And you can have an epidural that is going to grow very slowly. It's going to be kind of stable, and you don't have to take the patient to the OR right away. So I always try to say in my dictations, extraaxial collection. Sometimes it's difficult to say if it's subdural or epidural, but both components have to be evaluated by neurosurgery, and they can decide, okay, we just need to do a follow-up, or let's take the patient to the OR right away. Hemorrhagic contusion. So, for example, this patient, you're hitting both sides and you have blood in the parenchyma. Subdural and subarachnoid. You can see in the sylvian fissure and the basal cisterns how much hyperdense material is there because that's blood. And scalp hematoma, you can see how it's on the overlying the area of the fracture. Here. As I was saying, 3D reconstructions are really important for pediatric patients with trauma. I feel like if you are having patients that are many of them pediatrics and you are not doing 3D, it's going to be a problem. You're going to miss at some point something. So request it to your clinicians, request it to your radiologists too, because sometimes the sutures can look like they're fractures, or sometimes the fracture look like they're sutures. So if you have a 3D reconstruction, it's pretty obvious to see all the fractures. You can see the distribution if they're going to the sutures, and you can see the sutures itself. So this is an excellent tool, so take advantage of it. You can use 3D reconstruction for other things, like, for example, this patient doesn't have, it has closure of the sagittal suture, so this is crown synostosis. So don't use X-rays, use CT when you have a question for a fracture or a question with the sutures. The main concern about CT is what about cancer. Is this going to be my cancer or not, or my patients? So for the safety, these are going to be called is stochastic effect.